Our topic for today is paternalism, specifically paternalism as it shows up within medical practice. The term itself conveys this idea of kind of a parent looking after their child. So the idea that a parent knows what's best for their child and then takes care of them, makes choices on their behalf. With that image in mind, paternalism in medicine is something like when physicians or medical teams or medical personnel treat patients like children. So situations where a patient might be thought to not have the capacity to make their own decisions, the physician might step in and try to make decisions on their behalf. Or there might just be a third party that steps in to make decisions for the patient. That could be the courts, that could be a family member of the patient. But whatever the case, when it comes to paternalism in medical practice, the idea is the patient shouldn't be making their own decisions about treatment or about healthcare. And so someone else steps in and serves as kind of the parent to make decisions on the patient's behalf. And one thought up front is that paternalism is not an inherently bad thing. So you might think a good parent will behave in a paternalistic way towards their child. Their child might want to eat all sorts of junk food all the time, and a good parent is not going to let that happen. The parent, knowing better, makes decisions for the child and enforces those decisions. So the child isn't really given a decision-making power over their own diet, and we tend to think that's actually a good thing. You'd be a bad parent if you just let your child do whatever they wanted all the time. So again, paternalism is not automatically or inherently a negative thing. There might be cases where it's actually a good thing. Now that being said, I'll give you some formal terms here. Paternalism is going to be defined as acting in a way that is believed to protect or advance the interest of a person, even if acting in this way goes against the person's own immediate desires or limits the person's freedom of choice. So the idea in medicine would be, suppose a patient doesn't want a particular type of treatment and physicians give it to them anyway. That would be going against the wishes of the patient. The physicians see the treatment as a really good thing, as a benefit, and so force the patient to get this treatment whether the patient wants it or not. And we have to be really careful here too, because based on this definition, paternalism can still occur in situations where patients are cooperating. So as an example, suppose a patient comes in, they've had a stroke, and so the best treatment for them, medically speaking, would be to get blood thinners, and so physicians recommend this course of treatment, and the patient says, yeah, okay, I accept that. Then we go and ask the physicians, well, what if the patient had said no? What would you have done? And the physician says, well, if they had said no, I still would have given him this treatment. If that's the case, if physicians or third parties are saying, we're going to do this particular course of treatment whether the patient wants it or not, that still counts as paternalistic, even in cases where the patient says, yes, I agree, that is the right treatment for me. The physician who says, I'm going to give my stroke patient blood thinners whether they want it or not, that's paternalistic even if the patient says, yes, I agree, this is a good treatment for me. So paternalism at the core is limiting somebody's choices or freedom, making a choice on behalf of the person, whether it conflicts with their desires or not. Now, when talking about autonomy, when we talked about principalism, we said there might be cases in which it's actually okay to limit a patient's choice or to limit a person's choice more generally. Specifically, in cases where a person threatens the rights of others, we tend to think society can step in and stop that from happening. So if I attempt to steal someone else's property, that's me interfering with the other person's rights. Society has every right to step in and stop that from happening because I don't have the freedom to take what's not mine. Or put differently, your right to autonomous decision-making stops as soon as you start interfering with other people's rights. You don't have a right to freedom if, when exercising that freedom, you're undermining or threatening the rights of others. So in a similar way, you could say society is being somewhat paternalistic by saying my freedom is restricted to cases where I'm not interfering with anyone else's rights. But for our purposes, there are two other types of limitations that are really important for today, and those are weak paternalism and strong paternalism. So weak paternalism is defined like this: we are justified in restricting someone's freedom to act if doing so is necessary to prevent them from harming themselves. So if a patient comes into the ER and is threatening to harm themselves and physicians prevent that from happening, that is paternalistic. You're taking away the patient's choice to harm themselves, but we might think this is a perfectly fine thing to do. It's okay to be paternalistic here. It's okay to take away the patient's choice because that choice is self-destructive. So again, the idea is paternalism might not always be a bad thing. When it comes to strong paternalism, though, this is more controversial. So strong paternalism is defined like this: we are justified in restricting someone's freedom to act if by doing so we can benefit them. So here we're saying, not only are we going to take away your freedom when you're a threat to yourself or a threat to others, but we're going to take away your freedom when we know better than you what's good for you. So think about, in a medical context, if a physician says getting this particular treatment is what's best for the patient, and the patient says, no, I don't want that treatment, strong paternalism would be saying, you're going to get this treatment whether you want it or not, because I know what's best for you. So the Dax-Cowart case, which we've already discussed in this class, in that case, we had an individual who was very badly injured in an explosion, had third-degree burns all over his body, and throughout his treatment process, which went on for weeks and weeks, he kept telling physicians, I don't want to be treated, just let me die. Physicians in this case continued to treat him on the ground that the treatment was a benefit to him. It was going to help him. It was good for him to get treatment. And so this is strong paternalism in the sense that physicians are overriding a patient's decision because they think they know what's best for the patient. They think they know what's good for the patient. And so they're forcing the patient down that road whether the patient agrees with it or not. And so when we talk about paternalism in medicine, this is really the category that is the most controversial one. Questions about, can we undermine somebody's autonomy for the sake of beneficence? I'm just using the language of principalism here. We have the principle of beneficence, which tells us we ought to act in ways that promote the welfare of others. We have the principle of autonomy, which says we ought to respect self-governing rational beings, and in other words, let people live their lives as they see fit. And so in these cases, those principles are in conflict. We have on one hand physicians who want to benefit the patient, who want to promote the patient's welfare, and on the other hand, we have patients who don't want to cooperate with that. So what do we do in cases where physicians think a treatment is beneficial and the autonomous patient says, no, I don't want that treatment? Now, historically, this type of debate would probably go to the side of the physician. The physician, after all, is the expert in matters of health and well-being, and so the patient isn't really in a position to know what's best for themselves. So when you would have conflicts of personal decision-making of the patient versus what the doctor thinks is best, typically the doctor would win that fight. But then in the US, at least in the 60s and 70s, we started to see this strong push to defend patient autonomy. The idea being, physicians are not in a position to know what's best for particular patients. And the best judge of what's good for a particular person is that person themselves. So over the last 50 years or so, we've seen a huge push to try to empower patients to make their own decisions, which takes away from the power that physicians once had. This is a really oversimplified way of talking about it, but the idea was physicians knew what was best, you just did whatever they said, and now, over the last 50 years, the patient knows what's best, and it's up to the physician to just kind of go along with it, or at the very least, offer a range of options, and the patient is expected now to pick from a range of options what they think is best for themselves. So I think it's fair to say that there's been a very anti-paternalism movement in how medicine is practiced in terms of what patients' rights are, and those sorts of things over the last 50 years at least. And one last thought about this point. It might be really tempting to think of paternalistic physicians as being tyrants who are just drunk with power, who just want to control people's lives. And I don't think that's entirely fair. A more charitable way of looking at this is these are highly educated people who truly believe they know what's best for their patients. In many cases, at least, they don't simply wish to control the lives of patients. They're trying to promote their patients' welfare in the way that they think is best. In this way, again, if we go to the parent analogy, a parent who insists that their toddler eats a healthy diet, they're not doing it simply to try to exercise control over their toddler's life. They're not doing it for the sake of enjoying power over somebody else's decision-making. They're doing it because they think this is what's best for their child. And again, a parent that just lets their child do whatever they want is a very bad parent. So there's at least room for thinking that paternalism can be a good thing in various contexts. To put this point very simply, just because a doctor or a physician or a medical team or a committee is acting in a kind of paternalistic way, that doesn't mean that they're doing it with bad intentions. They might truly intend to promote the health and the well-being of their patients. Whether or not paternalism is justified or not, that's a different question, but the point I'm just trying to express is we shouldn't be thinking of paternalistic physicians as just tyrants who are drunk with power. There's more to the conversation than that. We might expect medical personnel to do what's best for their patients as well, and sometimes that means challenging the patient's own decision. There are also tons of paternalistic practices and policies in medicine today. You can't just go to a pharmacy and buy any drug that you want. And the reason is because you don't have the right education, you don't know what's good for you. So we limit your freedom, we limit your autonomy, your access to these drugs because you don't have the requisite knowledge and training to know what's good for you or what's not. This is paternalistic, whereas a non-paternalistic system would say, whatever you want to choose for yourself, just do that. Instead, what we have today is physicians write prescriptions because they're the experts in the matter. They know what's best for their patients regarding prescriptions. And so patients have to go to their physicians because the patients themselves don't have that knowledge. And this is how they get access to the treatment that's actually good for them. So the patient's freedom of choice is already drastically limited today in a kind of paternalistic way. But if you think there's really nothing wrong with that, in fact, it's a good thing that patients don't have access to whatever drugs they want, then that just shows that paternalism is not necessarily a bad thing. So this just drives us to the main question for today. When, if ever, is paternalism justified in medicine? Are physicians permitted to stop patients from acting in ways that are harmful towards others? Are physicians justified in acting in ways that limit the patient's autonomy, take away their freedom of choice in ways that are good for the patient? And so we have two extreme answers that we can kind of throw out right away. One is physicians should be in total control of their patients' lives. Their diet, their sleep schedule, every aspect of the patient's life comes under the control of the physician in the name of promoting the patient's health. Now that would be maximum paternalism, and I don't think anyone is going to defend the view that this is an okay or a justifiable way for medicine to operate. On the other side of the extremes, you have total autonomy given to the patient, where literally the patient can ask the physician for anything and the physician just has to comply. So if we maximize patient autonomy, the physician is in no position to ever go against the wishes of the patient. So if a patient comes into a clinic and says, I want you to amputate my left arm just because I don't like it, the physician is in no position to say no to that procedure and just has to go along with it if patient autonomy is the only thing that matters. So what this shows is, if we maximize paternalism, that seems really unreasonable. If we maximize patient autonomy, that seems really unreasonable. Physicians should have some say in what treatments they offer and what treatment protocols they promote for their patients. So we need to strike a balance between beneficence, doing what's good for a patient, and autonomy, allowing the patient to make their own decisions. Neither party, neither the physician nor the patient, should have total control over decision-making when it comes to medicine. So how do we strike the balance between the power given to physicians and the power given to patients? Or put differently, how do we strike the balance between beneficence from the physician's perspective and autonomy from the patient's perspective? For today, we're looking at an essay by Honora O'Neill, who presents us with a really helpful way of trying to balance the power dynamics between physicians and patients. So to start, autonomy is thought of as a fundamental principle in bioethics. So we looked at Beecham and Childers' principalism. Autonomy is thought of as the first principle among equals. It tends to dominate the other principles like beneficence, non-maleficence, justice. And so it has a very central place in bioethical decision-making today. But O'Neill says autonomy is not really a great principle to have at the center of how clinical ethics operate. In other words, when we're talking about a clinical setting, where physicians and patients are trying to make decisions about medical treatment, the idea is patient autonomy is already compromised. So O'Neill says this: since illness often damages autonomy, concern to respect it does not seem a promising fundamental principle for medical ethics. This is because patients standardly have reduced cognitive and volitional capacities. Putting this simply, in a clinical setting, the patients that physicians see are typically injured or ill, and being injured or ill or in pain, all of those things impede the ability to make good decisions. So if the typical clinician is seeing patients that have their autonomy, their decision-making powers inhibited, then honoring patient autonomy is going to be really tricky. Just to give you an example, a question that I like to ask students is, have you ever taken an exam when you were sick? Say you had a really bad headache or you were nauseated. And the question I like to ask is, do you think that that illness affected your ability to do well on the test? In other words, if you have to take an exam and you have an extremely bad headache, is there good reason to think that the headache interferes with your ability to think clearly and to do well on the exam? And I think the universal answer here is yes, of course. If I have a terrible headache, I have a hard time concentrating. I might have a hard time remembering the material that I need to for the exam. So just by being in pain, having a headache, having an illness, that makes me a worse decision maker. I don't think as clearly. I don't think as rationally. But these are the very people who are coming into the clinic, people whose decision-making abilities are impeded by injury or illness. So when we say it's really important to do whatever the patient says, the patient may not be thinking clearly at all. They might be thoroughly distracted by pain or discomfort or whatever else is going on with them. And this gets even worse when we have conditions that we know deprive a person of their ability to make good decisions. So injuries to the head or strokes. These sorts of conditions take away the ability for the individual to make their own decisions. It impedes their ability to think clearly, to process, to reason, to understand what's being told to them, to understand what their options are for treatment, to think about what they value and what they don't, to think about whether a treatment is worth pursuing or not. All of that is compromised by injury and illness in many cases. So ONeill's point is, when people say it's super important to honor patient autonomy, it's not that simple. Patient autonomy is compromised already. And so what do we do in these cases? If we just do whatever the patient says, they might not be thinking clearly and they might make a decision they sincerely regret. That doesn't seem good for patient autonomy any more than acting in a paternalistic way does. You don't want to do something to someone that they're going to come to regret when they can think clearly, and you also may not want to take away their control over their lives either. So we're stuck in this difficult situation of what do we do with patients whose autonomy is compromised? And if ONeill's right, that's going to be most patients. Most patients have their autonomy compromised to some degree or another. One other way of thinking about this is ONeill draws a distinction between ideal patients and actual patients. The ideal patient is going to be someone who's reasonable, who's understanding and thoughtful, who's unaffected by coercion, unaffected by intimidation. They can think clearly, they understand everything that's being told to them, and whatever decision they make is coming from a very well-reasoned and well-thought-out place. So the ideal patient is the one that is perfectly capable of making decisions for themselves. The actual agent, on the other hand, the people who come into the clinic every day, is the person who may be reasonable, maybe not. They might have a limited understanding. They might not really get what the physician is telling to them. They might not understand the implications of different treatment options. They might be prone to coercion. They might be confused, or they might be intimidated. So treating the ideal agent, that's going to be really easy. You just let them make whatever decisions they want because you know they understand everything, they've processed everything, and whatever decision they make, it's truly the one they want. The actual patient, on the other hand, varies widely. Some are going to have a deep understanding of what's going on. Some are not going to understand a thing. Some are going to be confused and so ask questions of the doctor to help clarify issues. Some are going to be confused and not say anything because they're too afraid to speak up. So actual patients are virtually never going to be ideal patients. So how do we deal with actual patients? How do we respect the autonomy of individuals while at the same time recognizing that autonomy is going to be compromised or undermined? The ability to make clear-headed decisions is threatened by injury and illness. How do we deal with these cases? And ONeill, I think, gives a really helpful way of thinking about this. To put the basic idea in a chart, the idea might be something like this. As somebody's decision-making power, so their ability to think clearly, their ability to understand what's being told to them, their ability to weigh different options, as that decision-making power diminishes or declines, paternalism needs to increase. So the less a patient is able to make their own decisions, to think clearly, the more they need someone else to make decisions on their behalf. And this means that the decision-making power of the patient and the paternalistic practice of the physician are kind of in an inverse relationship. Where decision-making power decreases, paternalism needs to increase, and by the same token, as decision-making power increases, paternalism needs to back down as well. So take the Dax Cowart case. This was a situation where, at the time of his injury, he might not have been able to make any decisions for himself. He was in tremendous amounts of pain, and so paternalism needs to be maximized there because he really has no capacity to make his own decisions. But over time, as he's healing, as he's getting better, his decision-making power is also increasing, and if ONeill's right, that means paternalism has to back down as well. So for example, if somebody has a brain injury, at the moment of the injury, they might have no capacity to make their own decisions. Based on ONeill's chart, that would mean we have to act in a strictly paternalistic way. They have no decision-making power of their own, so we have to make decisions for them. But over time, the brain injury might begin to heal. And so as it heals, the patient might regain more and more of their decision-making powers. They might be able to think more clearly, to reason more carefully, to understand what's being told to them to a deeper degree. And as that happens, as the decision-making power continues to grow, paternalism needs to be backing off in proportion. Now, this doesn't give us an exact answer as to when is paternalism okay or not. Rather, it tells us that paternalism is justified to the degree that the patient's decision-making power is diminished. So it's up to physicians to determine two things. First, how diminished is the patient's decision-making power? If it's extremely diminished, then that means physicians have to act in a very paternalistic way. If it's moderately diminished, then physicians should act in a moderately paternalistic way. And if the patient's decision-making power is barely diminished, then there should be no sort of paternalistic practice at all. So physicians have to assess how diminished is this individual's decision-making ability, and then they act in whatever way is appropriate based on ONeill's recommendation. A second thing that physicians have to be careful about, for ONeill at least, is not falling prey to the temptation to just act in a paternalistic way when someone's autonomy or someone's decision-making power is compromised. So somebody whose decision-making power is moderately compromised by their illness or injury, it might be tempting for physicians to just go full paternalistic mode and just make decisions for the patient. But ONeill is saying physicians have to be really careful to back their paternalistic practices down when the patient has some capacity to make their own decisions. So this chart that ONeill gives us, it doesn't give us an exact answer as to how we should act in any given situation. All it says is that physicians have to tune into the particularities of each case by case, and determine how much decision-making power does the patient have, and then act in a paternalistic way in proportion to that. And throughout this discussion, I've been talking about just two parties, the patient and the physician, but really, when it comes to paternalism, we have the patient and a third party. The third party could be a physician, the third party could be family members, it could be friends. The idea for ONeill is that as a patient's decision-making power is diminished, a third party has to take up the slack and make decisions on behalf of the patient to the degree that the patient's decision-making power has been diminished. So paternalism doesn't just hold between medical personnel and patients, it also holds between third parties and patients, where those third parties might be family members who are making decisions on behalf of the patient. But again, ONeill's account is going to work all the same, saying that third parties can step in to make decisions for patients to the degree that the patient's own decision-making power is compromised. So what this means is the principle of beneficence, doing good, promoting the well-being of patients, that can't be the only principle that we take into account. If it were, then we would just say medicine should proceed in a totally paternalistic way, where physicians have in their head the idea of what's best for the patients, and they just do that all the time. On the other hand, patient autonomy can't be the only principle that matters either, because patients' own decision-making powers are often limited or compromised by their conditions. So we can't just do whatever patients want whenever they want it. For one thing, that would almost certainly require violating non-maleficence, where patients might ask for a procedure that's extremely harmful and unnecessary, and physicians, if they hold seriously to the idea that they should do no harm, they should obey this principle of non-maleficence, they're not going to be able to comply with those patients' requests. So if a patient asks for a harmful treatment, a physician who wants to satisfy the principle of non-maleficence has to say no. And if you think that's okay, if you think it's okay for a physician to say no to a treatment that is going to harm the patient and not help them at all, then patient autonomy is not the only thing that matters. So for O'Neill, there are a few situations in which paternalism is going to be justified. In cases where a patient has temporary loss of autonomy, those are cases where a third party has to step in and make decisions for the patient. Now, O'Neill's very careful to say, if it's truly a temporary loss of autonomy, temporary inhibition of the ability to make decisions, then as soon as that decision-making power is restored, as soon as the patient's able to make their own decisions, paternalism has to go away. So paternalism is okay when a patient temporarily has lost their decision-making power, but it's not okay as soon as the patient regains that decision-making power. Secondly, O'Neill says that when there's a long-term or permanent impairment of autonomy, then paternalism is okay to some extent. So somebody might be able to make very simple decisions, but not complicated ones. In those cases, their decision-making power is impaired, maybe permanently. They're never going to get to a situation where they can make complex decisions, but they're always going to be able to make simple ones. In those cases, paternalism is justified regarding the complicated decisions, but not justified regarding the simple ones. Even if somebody's decision-making power is permanently impaired, but not lost, physicians can exercise some degree of paternalism, but also have to respect whatever decision-making powers the patient does have. And this leaves the final category, permanent loss of autonomy. This is where a patient has lost their ability to make decisions through injury or illness, and there's no chance that it's coming back. In those cases where decision-making power has been lost forever, obviously a third party has to step in. They have to be fully paternalistic because the patient just has no ability to make their own decisions. If a patient is in a coma and we know they're not going to wake up from it, decisions have to be made on their behalf because the patient no longer has any capacities at all to make their own decisions. So in those cases where autonomy has been lost forever, paternalism is going to be fully justified. And the same sort of thing goes for somebody who was born never having the ability to make their own decisions through some sort of impairment or disease or injury. If somebody never develops the ability to make their own decisions, then yes, a third party has to step in and act in a paternalistic way, making decisions for that individual. But again, all this being said, O'Neill says very clearly, whatever decision-making power the patient has, to whatever extent, physicians have to respect that. And so total paternalism is not justified in cases where patients have some degree of decision-making power, some degree of ability to reason through and weigh options and make their own choices. Again, it comes down to paternalistic decision-making and paternalistic actions should be in proportion to how diminished the patient's decision-making powers are. So if the patient's decision-making power is minimal, physicians have to respect that. They can't be fully paternalistic. If the patient's decision-making power is moderate, then physicians have to be moderately paternalistic, but not more than that. And if patients really don't have any sort of limitations on their decision-making powers, they're thinking clearly, they're reasoning well, then paternalism is just not justified in those cases. So just to recap a little bit, we said paternalism is acting in a way that's believed to protect or advance the interest of a person, even if acting in this way goes against the person's own immediate desires or limits the person's freedom of choice. We looked at several different cases in which autonomy or freedom of decision-making might reasonably be limited. So we limit people's decision-making powers when they're going to harm other people. We might limit people's decision-making powers when they're going to harm themselves. And most controversially, we might limit somebody's decision-making powers when we think we know what's best for them. We think by limiting their powers, I can benefit them in some particular way. Then we looked at a couple considerations to keep in mind. Paternalism is not an inherently bad thing. It might well be justified in many cases. We asked the question, when is paternalism going to be justified? And O'Neill gives us an answer to this question. She argues that paternalism is justified in proportion to how diminished a patient's decision-making powers are. And decision-making powers can be diminished by injury or illness. So there are several tests that we can run. We might ask the question, does the patient have a condition that we know inhibits the ability to make decisions? And if so, then paternalism is required. And then secondly, we might test the patient's function as well. We might see how clearly are they thinking? How well can they reason? how much can they remember of what they're being told? And if they're not able to remember options, if they're not able to reason through different options that are available to them, then paternalism might seem justified in those cases. So if somebody's function is diminished, there are lots of tests that we can run to try to see how impaired is their decision-making ability. And if O'Neill is right, whenever somebody's decision-making ability is impaired to some degree or another, a third party is justified in stepping in to act in a paternalistic way to make decisions on behalf of the patient. Now, one limitation of this discussion is that really we've focused on two parties here. We've focused on the patient and a third party. Things are going to get even more complicated in situations where we have a conflict between physicians, a patient who's a child, and the child's parents. So O'Neill's account might work really well in cases where you have an adult patient, you're trying to decide whether or not a third party can make decisions on their behalf. But then when we look at cases of a patient who's a child, and then the parents and the physicians who might be fighting over which course of treatment is best, then the question is, who makes decisions in that case? Should we empower the physician or should we empower the parent? So we're getting to that in the next video. In the meantime, any questions about paternalism generally or how O'Neill's account is supposed to work, let me know about those and I'll get back to you in the comments.